All right, let's jump straight into this highly anticipated explainer. We're breaking down the ARISE Fluids trial results, which literally just dropped today, June 11th, 2026, in the New England Journal of Medicine. If you're an emergency physician or critical care provider, this is exactly the kind of practice-informing data you've been waiting for. We are going to look specifically at the early management of septic shock right at the front doors of the hospital.
As emergency physicians, you know this daily clinical dilemma all too well. You've got a patient presenting with suspected sepsis, you've given them their initial 1-liter fluid bolus, you've checked the lactate, and it's hanging out above 2.0, and yet they remain hypotensive. Their mean arterial pressure is still stubbornly sitting below 65. So, what is the optimal next step here? Do you push more fluids, aiming for that traditional 30 milliliters per kilogram target, or do you pull the trigger on early vasopressors to clamp down the vasculature and restrict further fluid? Until now, we've had pretty limited high-quality evidence to guide us, which has led to a massive amount of practice variation across the board. Well, to finally address the clinical equipoise surrounding this exact question, the ARISE Fluids trial stepped up. They randomly assigned 1,000 adult emergency department patients into 2 distinct treatment pathways across 51 sites in 3 countries. And the best part? This wasn't some study looking at ICU patients hours into their admission. This was an emergency department trial capturing patients right at the front doors, right in those critical early hours of undifferentiated shock.
So we're looking at a head-to-head comparison here. On one side, we have the vasopressor group, which utilizes restricted fluids and early vasopressor therapy. And on the flip side, we have the fluids group, relying on the higher fluid volumes we've all historically been trained to give, coupled with later vasopressor initiation. The trial delivered these interventions for at least 6 hours and up to 24 hours while the patient remained in a critical care setting.
This breakdown gives us a really clear, tangible look at what restricted versus liberal actually meant in the trenches. For the vasopressor group, intravenous resuscitation fluids were seized immediately after randomization. Boom, done. Vasopressor therapy commenced right away, and further fluids were only given as strict 250 milliliter boluses if clinically indicated by persistent hypoperfusion. Now contrast that with the fluids group, where patients received an immediate fluid bolus of up to a full liter within the first hour, followed by additional 500 milliliter boluses as needed. For that group, vasopressors only started once the clinician felt the fluid level was adequately restored.
Now what's really fascinating here is the clear separation they actually achieved. You know how it is with pragmatic trials. Sometimes the groups end up getting treated kind of similarly anyway, but not here. In the first 24 hours, the vasopressor group received a median fluid volume of just over a liter, while the fluids group received about 2.25 liters. That is roughly half the fluid volume. Furthermore, the median time to start vasopressors was just 0.4 hours in the restricted group compared to 1.4 hours in the fluids group, so the investigators successfully tested 2 truly different physiological approaches.
Okay, drumroll please. Let's talk about the primary outcome. The investigators looked at days alive and out of the hospital at day 90. It's a fantastic, patient-centered metric that combines both mortality and hospital length of stay. And the result? Exactly 76 median days for the vasopressor group. And for the liberal fluids group, also exactly 76 median days.
Yeah, absolutely zero statistical difference, with a p-value of literally 1.00 between the early vasopressor and liberal fluid groups. Secondary outcomes, like 90-day mortality, were also totally similar, sitting right around 14 to 16% for both groups. Now, instead of framing this as some boring anticlimax, this finding is actually totally liberating for us. We all know that historical anxiety of starting a peripheral pressor versus the psychological ease of just hanging yet another bag of saline. Well, this proves that neither pathway inherently compromises long-term patient survival. You are for sure not tanking your patient's 90-day trajectory by choosing to start that pressor drip early.
But hang on, we definitely need to look at the safety data because this is where things really diverged. While survival was equal, the complications absolutely were not. Pulmonary edema occurred in 5% of the patients in the fluids group. Compare that to a mere 0.6% in the restricted vasopressor group. That is a highly statistically significant difference, and clinically, it's a massive deal for us in the ER trying to avoid the iatrogenic harm of fluid overloading a patient straight onto a ventilator.
And look, these results don't exist in a vacuum. The ARISE trial investigators explicitly note that these findings align perfectly with the recent CLOVERS study. You might remember the CLOVERS trial also looked at a 24-hour restricted fluid strategy for sepsis-induced hypotension, and they also found no mortality benefit over a liberal strategy. When we put ARISE and CLOVERS side by side, we see a highly consistent narrative emerging in modern critical care. Mindlessly pushing massive volumes of fluid is simply not saving more lives than a tailored, vasopressor-supported approach.
So, what's the big takeaway from all this ARISE and CLOVERS data? First, recognize that overall survival outcomes are equivalent between both resuscitation strategies. This no difference finding is a really good thing. It empowers you to individualize patient care rather than following some rigid, one-size-fits-all fluid mandate. Second, adopting a restricted fluid and early vasopressor approach safely and significantly minimizes the risk of pulmonary edema. Therefore, our core recommendation encircled by these trial results is this: strongly consider reaching for early peripheral pressors, especially for your ED patients who have pre-existing conditions making them susceptible to fluid overload, like heart failure or end-stage renal disease.
For the deep dive into the methodology and all those juicy subgroup analyses, you'll want to check out the original manuscript by Peake et al. Titled Vasopressors or Fluids in Early Septic Shock in the New England Journal of Medicine. With the evidence now clearly supporting the safety of individualized early vasopressor care, it leaves us with one final question. On your next shift, will you instinctively reach for that next liter of saline, or is it finally time to confidently hook up the pressors?